Good morning, good afternoon, good evening, everyone. Welcome to this session on health system governance and more specifically on evaluating health systems governance and accountability, diverse lenses and approaches. Despite all the challenges of coming together in this health system governance and health system global meeting conference in Dubai, as it was originally planned, we have been able to bring together our speakers today who are going to present their respective work. And we thank very much the organizers for allowing such a wonderful platform and live sessions despite all the challenges that we are facing this year. I would like to thank all the speakers today. First, I will introduce myself. I am Mariam Bigdeli. I'm the WHO representative in Morocco, where I am right now. I'm in Rabat. I have been in WHO for a number of years, and I've been working on health system strengthening, health system research, governance, and access to medicines. This session is bringing us a number of speakers who have pre-recorded their sessions through video. So we hope that we will have a seamless presentation from them, but they're also here with us to answer a live Q&A. I would like to give you a few tips to be able to engage with our speakers today through the platform that we are using for the conference. As you can see on this slide, when you are logged in this platform, you have a chat and a Q&A session. And this is extremely important for you to be able to go in this on this platform, use the live Q&A to be able to make your comments and ask your questions to our speakers today. You will better experience this through a full screen show of the platform. So put your screen on full screen. The sessions are recorded and you will be able to log in again and see them later on until the 31st of March. Here is our first speaker. I would like to introduce Sarah Fisher, who is going to present us her work about who owns development projects, theory versus practice in Malawi's health sector. Sarah is a PhD student from Georgetown University in USA. She's a PhD candidate in the Department of Government at Georgetown University. Her dissertation research employs a critical ethnographic approach to investigating how community health systems in Malawi is shaped by domestic and external pressures, with a focus on donor and NGO projects. She hopes that after her PhD, she will expand her research agenda to include more on global governance of health policy and systems. I would like to let now our hosts play the pre-recorded session of Dr. Fisher.
Hello, my name is Sarah Fisher, and I will be presenting a manuscript based on my dissertation data entitled Who Owns Development Projects? Theory versus Practice in Malawi's Health Sector. Now, ownership is a sort of buzzword in international development circles, but as you begin to look around at facilities and communities, you begin to notice donor or project branding, as you can see, for example, from this sign at Malombe Health Center in Malawi. So I began to ask myself what is actually meant by ownership and who exactly is or should be doing that owning. Now, development discourse has emphasized the principle of country ownership since at least the 2005 Paris Declaration. However, ownership denotes possession, usually by purchase. So if we consider the ODA budget, which was $153 billion in 2019 alone, we might be concerned that we'll see donors possessing recipient governments or having power or mastery over them, as this definition suggests. So what I'm asking here is, who really owns development? So I want to suggest that the way that we think about ownership is wrong. And basic principal agent theory would suggest that there is a principal, in this case the donor, that contracts an agent, in this case the recipient or national government, to undertake certain actions on their behalf, in this case development projects. Now, conventional development understanding is that the donor has a project, they give the money to the recipient, and the recipient then carries out that project. However, in development context, there are two major problems with that assumption. First, given the pillar of ownership in aid effectiveness, the principal should really not be the donor. In fact, it should be the recipient who is deciding which services to offer or which programs to run, which the contracted agent or the donor will then fulfill with funding. So given this, the conventional principal-agent relationship would be flipped on its head, such that the recipient government becomes the principal and the donor the agent. However, there's a second issue that emerges with this framework as well, and that is that development does not simply consist of a bilateral donor and recipient. In fact, many more actors are involved, and as the brilliant Kimi Dian shows in her book Doomed Interventions, there are multiple cascading principal-agent relationships that could and do occur from bilateral governments all the way down to communities themselves. So these other actors, including district and local governments, NGOs, health workers, and the communities themselves, should not only be part of the project ownership chain, but there really should be a bottom-up chain from communities to national governments, all acting as principals to the external actor agents. So the main takeaway here is that the way we conceive of principal-agent relationships in the context of development project ownership is incomplete. So to demonstrate, I have examples from various levels across the development lifecycle, from country to community ownership. So first here, you often see national government stakeholders saying that projects being brought to Malawi are in fact government of Malawi projects, and that partners are just supporting, as in this quote. This is the way it should be. This is the way it's conceived in the Paris Declaration and in the literature. And this is also mainly the perspective that you get when you talk to donors, national MOH staff, and NGO personnel, really anyone headquartered in Lilongwe, Malawi's capital city. However, there is, of course, more to it than that, because at the next level, you have districts. And with an increasing focus on decentralization, districts should be taking as much, if not more, ownership of development projects than the national government, as you see, for example, in this first quote here. However, there is sometimes a lack of translation from national to district level, whereby projects are planned at headquarters and districts need encouragement to quote unquote take ownership, as you see in the second quote, where a supporting partner is pleading with government officers, don't look at this as a partner-driven activity. It's wrong. It's your own DHO, district health office activity. But of course, districts are where projects are actually run, so they really need to be part of that ownership chain as principals. Moreover, district employed health workers are a necessary cog in that system. So here, for example, are two quotes from Health Surveillance Assistance, or the Government of Malawi Community Health Worker Cadre. The first one shows the frustration that HSAs often have with projects bypassing them to implement directly in communities. Others go into our catchment area without our knowledge, so that disappoints us, because when there are activities, as I am the owner, I am supposed to be aware of what is happening, but they just go without our knowledge. So they really consider themselves to be the owners of their particular catchment areas. Then you also see that even when an HSA does try to take some ownership of the project, there's a difficulty in translating that down to communities, as you see in this second quote, where one HSA says, if we go there, we remind them about what they're supposed to do, they don't understand. They think that the program is for the NGO. So this brings us to the final stage of the ownership chain, the intended beneficiaries of all these projects, or the communities. Now, all of the frontline workers, NGOs, government officers, all of them acknowledge that communities must feel a sense of ownership over projects in order for them to be successful, as you see in this first quote. However, this is often not the case. And as I showed in the district quote above, I have observed a lot of pleading with communities to try to get them to feel that sense of ownership, and often to no avail. So here, one HSA describes that the community should feel a sense of ownership. They should feel that it's their own thing. We had a challenge where we were supposed to receive boreholes, and I discussed this with them. No, this is important, but I don't know whether it was important to them. So this demonstrates the importance of ensuring ownership, not only at the country level, but even all the way down to communities themselves. So to conclude, we have seen that there is of course an aspect of bilateral country ownership that plays a role in development. That goes without saying. However, most development projects are not implemented at the national level. So ensuring country ownership alone is insufficient. Now, everyone mentioned that these subnational stakeholders, from district health offices to communities themselves, must also take ownership of development projects. So we must reconceptualize communities, frontline workers, districts, and countries as principals in the development chain, while seeing donors and implementing partners as the agents. So to have development projects be truly owned, there needs to be a more nuanced understanding of who the owners are or should be. And imagine a world in which the Malombe Health Center sign that I showed at the beginning looked more like this, with only the government insignia displayed and perhaps Mangochi District Council or even the names of surrounding communities. And this is what I argue that ownership should really look like. Thank you very much for your time.
Thank you very much, Dr. Fisher, for this very interesting and inspiring presentation, first presentation. We will move through all the presenters and their videos before taking the questions and answers. So please, the audience, bear with us and be patient until we've heard from all of our guests today. So the next speaker is Dr. Armand Argeles. I do hope that I pronounce your name correctly, and apologies if I don't. Dr. Argeles will talk about unpacking social injustice in government decision-making, potential for retrospective health impact assessment. Armand is a health promotion specialist from the Department of Health in the Philippines. Is a practitioner of health impact assessment and health promotion. He works to co-create healthy cities and communities through research, policy, and collaboration. Welcome, Armand, with us, and we are ready to see and watch and listen to your video.
Good day to everyone. On behalf of my research partner, Ms. Frances Onagan, we'll be presenting to you started out as a vision paper for how retrospective health impact assessment can be useful in surfacing injustices or implications to the social life and dynamics in a given community as they are caused by lapses in government decision making. So health impact assessment, or HIA, is commonly used as a decision support tool for evaluating the potential impacts of proposed projects to health. It is mainly prospectively applied because the idea is to safeguard communities before they even get introduced to development projects. Now, of course, a lot of these projects get approved because the proposals were still in paper, and there are negative effects that manifest only after approval has been issued or when operations are already ongoing. Aside from that, I think it's important to note that HIA in the Philippines has been, for the longest time, it's only a small portion of the environmental impact assessment, a regulatory function owned by the Department of Environment. It follows that HIA has been heavily focused on the physical and environment-related dimensions in each individual development or infrastructure project. So these dimensions mostly include ambient air quality, water quality, etc. It's important also to note that under this current practice, decision-making has mostly relied on data as they are presented by technical experts, which mostly include engineers, toxicologists, air or water resource experts. With this presentation, what we aim is to forward retrospective HIA as a new methodology to systematically surface experiences of negative health effects that emanate from the project only after approval has been granted. At the same time, what we aim is to forward retrospective HIA as a means to trigger reforms at the governance level, which allow these lapses in decision making in the first place. Now, this is the modified research and review framework for retrospective HIA that we have piloted in a community where there's already a development project in operation. It adopts the usual HIA stages from screening to monitoring, but the one pertinent feature of this modified HIA framework is the gravity that it puts to public scoping, public review and recommendations, and subsequent policy influencing. Now, previously, the HIA process was conducted in a very silo manner, and the assessment is done and over after each individual project. We piloted the retrospective HIA process in one local municipality here in the Philippines, where a coal-fired power plant is permitted to operate. Now, using the modified framework, we were able to engage not only with technical experts, but meaningfully as well with the community, as we treat them as co-assessors or co-creators of data and possible health impacts that the development project may introduce to their community. Among the activities that we've conducted with them include documents review, community scoping. We did workshops on timeline technique and causal pathway, also storytelling and structured discussions. These activities, which we are hoping to mainstream in the HIA practice, help us to facilitate a more systematic and highly participatory gathering and review of data. Now, interestingly, these activities provided us also a means to document their realities and experiences in the community, which, as it turned out, were not really considered in the HIA report that was originally presented during the time when the project was on its approval phase. All of this we use to complement and enrich the data from technical experts that we have. Alas, using findings from the retrospective HIA that we did, we were able to surface these adverse effects to community health and other crucially important health determinants. These effects were absent in the HIA report originally conducted, which was basis for approving the project. Number one, we learned that there was very limited participation in the review and decision-making process. The community was hardly consulted, and technical experts were provided more weight during the assessment and approval. Secondly, the original report did not predict effects to local employment or loss of sources of livelihood. The community was largely agricultural, with many small-time farmers and fisher folks, and negative effects to their sources of income have been observed in the community. For example, the coal plant continuously dumped their ash wastes near the farming area. The coal plant management, because they have their port facility as well, they also barricaded and prohibited local fisher folks from entering their usual fishing areas. Third, a lot of families have been displaced and they have been living in the village for many years. Worse, the relocation alternative provided to them were substandard and could be harmful than beneficial for them, as you can see in the photo. Finally, the discussion on the cost and benefit of hosting the coal plant in the community has heavily polarized the communities between the supporters and the dissenters of the project and the local government versus the organized groups. As an effect, there has been an equal distribution of social support and services between the supporters and the dissenters of the project. Some groups were even tagged as leftists, resulting in poor social status and social capital in the community. Ultimately, these implications or effects to supposed access to basic services may be attributed to poor decision making and regulatory processes that permitted the project to operate in the first place. In sum, we can say that retrospective health impact assessment provides for a systematic means to, number one, highlight the value of local knowledge. Retrospective HIA may be useful for calling out the unequal regard and value for technical and local knowledge in terms of evidence as basis for decision making. Number two, it surfaces the lapses in current regulatory processes. Retrospective HIA may be useful in surfacing the project's negative implications to the most basic and most important determinants of health, which then may trigger policy and process reforms. Finally, HIA highlights the value for a multi-sectoral involvement in the review and approval of development projects. In the test case that we did, it was found that only the Department of Environment was involved when the project was first granted approval. Now, because the retrospective HIA shows that implications to the community go beyond just the environment, it was highlighted that participation of offices with relevant mandates may be included in the process. All of these findings we have presented to the country's planning department during its interagency meeting. Successfully enough, the findings have compelled member agencies to reflect on their respective processes, and these provisions have been successfully integrated in the Universal Healthcare Law and its implementing rules, citing specifically the need to generate and consider local knowledge for the review procedures and the explicit role of different other government agencies in the process. So included the planning department, the Department of Local Government in the Interior, not just the Department of Environment. This is to ensure that lapses in decision making will be minimized, and that the health and well-being of the community and their access to services that likewise determine their health outcomes will be safeguarded. So I think that's it for our presentation. Thank you very much for listening.
Thank you very much for the second presentation, which is very also interesting as linking this health impact assessment through a participatory process to our previous presentation, which was looking at community ownership, and we'll discuss that more in our Q&A. I would like to introduce now our next speaker, Dr. Andre van Rensburg, who will talk about intersectoral governance for health system strengthening in South Africa, and more specifically about challenges and prospects in community-based care for severe mental illness. Dr. van Rensburg is a senior researcher of the University of KwaZulu-Natal. He's a senior researcher in health systems at the Center for Rural Health in KwaZulu-Natal, Durban, South Africa. He's a social scientist by training with a doctoral qualification in political science and sociology, and is currently developing a research program on integrated community services for severe mental disorders. I think we are ready to watch the video recording of Dr. van Rensburg's presentation.
Hi everybody, my name is Andre van Rensburg. I'm a senior researcher at the University of KwaZulu-Natal in sunny Durban, South Africa. Thank you so much for tuning into this presentation, which is titled Intersectoral Governance for Health System Strengthening in South Africa, Challenges and Prospects in Community-Based Care for Severe Mental Illness. Now, in order for us to proceed, we first need to establish some key facts, the first of which relates to mental illness as a substantial vulnerability. Here we take the point that people living with severe mental illness are 2 to 3 times more likely to suffer from excess mortality than the general population, a ratio that no doubt will become much worse in the context of COVID-19. People living with severe mental illness also are poorly integrated with wider systems. They're exposed to much more risk, and they have very little voice and power to advocate for improved services. Now, as the deinstitutionalization experiments of the 1970s taught us, people with severe mental illness, when they transfer to community settings, they demand complex system requirements. Now, in terms of health system arrangements, the literature is pretty much unequivocal no matter the country or population. In order for people with severe mental illness to be able to live in communities, we need strong integration, strong collaboration, and strong partnership across sectors and across state and non-state entities. Now, this needs to go beyond health and social services, and we need to involve multiple sectors in developing care systems on a community level. Now, among the more important consequences of such arrangements is the central consideration of public policy. So what kind of policies do we need that can facilitate appropriate action in an integrated way? Now, today's presentation will focus on South Africa, a country with many valuable health system lessons during the past 25 years, and this includes the introduction of legislation policies driven by social justice and human rights, much stronger civil society, but also very strong participation in global health processes like its inclusion in the movement for global mental health. But there are also critical failures that we need to consider here. This includes community-based mental health care that remain extremely weak and very underdeveloped, and also funding that flows much more to hospital and psychiatric-driven care than to community-based systems. Many of these failures were very dramatically exposed during the Life is Many tragedy in 2016, where 144 people suffering from severe mental and neurological conditions died due to neglect following a deinstitutionalization attempt by the states, and many of them still remain missing today. Now, there are several issues that were raised during this process, several lessons that we took on board. There's issues of political competence and governance, the lack of prioritization for community-based systems, and a growing rift between the state and civil society. An important omission here, an important missing narrative, was the critical failure of intersectoral working, and it remains unclear to what extent South Africa's public policy arena provides the foundations for intersectoral action for community-based care. Now, the driving aim of this study was what governance mechanisms support comprehensive community-based care for severe mental illness in South Africa. And we conducted a framework analysis of 28 national and subnational documents across all sectors, using an a priori framework from McQueen et al. Called the Analytical Framework for Intersectoral Governance. This also allowed us to include important emergent inductive themes. Now, in terms of these initial inductive themes and impressions, we realized that South Africa's public policy is very much driven by goals of restitution, poverty alleviation, empowerment, and equitable service access. The values of collaboration and partnership goes across sectors and between state and non-state entities. And especially, an especially important goal was to give more power to communities. Now, key insights seem to be that there is a lack of conceptual clarity on the boundaries of severe mental illness, whereas in the Department of Health and the health sector in general, it was tend to be framed in terms of biomedical terms in a DSM way. In other sectors, it was placed alongside other forms of what is termed disabilities. Now, while the establishment of provincial mental health and substance abuse directorates are meant to prioritize mental health, it could also have an unintended effect of further biomedicalizing mental health into facility-based care, since community care is still very much in its infancy. Now, in terms of the forms of intersectoral action across the policy sectors, and for the sake of time, we just touched on some of the more pertinent issues that arose in our analysis. So a key question is whether the policies are aligned towards the same goals and targets. And here the documents were relatively well aligned and anchored by the Bill of Rights and South Africa's Constitution. Monitoring and evaluation across sectors was especially wanting, since well-coordinated data collection was not well operationalized across sectors, if at all. In terms of financial support, intersectoral action does not have dedicated funds for meetings, etc., and these tend to be taken up by forms such as district-level forums for mental health and district-level forums for substance abuse, but these are not well integrated across. Implementation and management for the for intersectoral action was exemplified by Operation Tsukumisake, which is a whole of government approach that is in play in the province of KwaZulu-Natal at the moment. It's based in a community level committee which is empowered to identify local challenges on a weekly basis and respond by directing relative funds and relative sectors towards solving these issues. So this is a mechanism that is sorely missing in developing community mental health care for severe mental illness. So in conclusion, we can say that although mental health sector stewardship is instrumental to effect community care for severe mental illness, a close and sustained involvement of other sectors are also vital. South Africa's mental health policy comes to an end this year, and there are several important lessons that we can take on board to improve care for severe mental illness. And this includes decentralizing care to local task teams beyond provincial governance to respond in a culturally appropriate and a more effective manner. And this should also be driven by equity, accountability, and participation of people with severe mental illness as well as their families. The ultimate message is a well-known one, that the community care for severe mental illness can only be achieved in an appropriate manner through broad stakeholder involvement, engaged and transparent regulation. So I thank you for your time and attention. I'd be happy to expand on any of the aspects that were covered or not covered here, and feel free to contact me. Thank you.
Thank you very much for this presentation on a interesting topic of mental health and at community level. I'd like to move on to our next speaker, Dr. Benita Adhikari, who will talk about applying the functional analysis framework with core functions to reform the Ministry of Health, an experience from the Indian state of Uttar Pradesh. Dr. Adhikari is a research associate from Johns Hopkins School of Public Health in Nepal. Benita Adhikari is a health system implementation researcher, which has 6 years of experience in leading field research activities in developing countries. Her research is related to understanding governance and accountability mechanisms for institutional strengthening of public health sector organizations in low and middle income countries. We'd like to move to her presentation if our hosts are ready. Video recorded presentation.
Hello, everybody. My name is Benita Adhikari. Today, I'm going to talk about our experience of supporting the reform of Directorate of Medical Health of the state of Uttar Pradesh in India. We utilize this approach of functional analysis that incorporates core functions. Today, I'm representing my team from Johns Hopkins Bloomberg School of Public Health. So we're all aware that the health system priorities are quickly changing due to the emergence of new diseases, actors, and technologies. In this context, the community of global health leaders have been raising the agenda of establishing strong ministries and public health organizations that can adapt to new demands. However, there seems to be few practical tools that are available that really guides practitioners and policymakers who want to embark on strengthening their organizations. While integration of complexity and system sciences have helped policy and health system researchers to characterize health system and the emerging context, the current literature offers very little guidance to our policymakers on how to approach and operationalize this global health agenda of building a strong public health organization in this emerging context. From our experience in Uttar Pradesh, what we found was that the functional analysis approach that was popularly utilized in public administration practice could be a new analytical tool that can be utilized to systematically assess public health organizations and devise institutional reform strategies to strengthen them. This is a process that assists policymakers and planners, especially in low and middle income country, to really self-reflect upon what is working and what is not working within their own organizations. So as you can see on the screen, in this framework that is presented on the right-hand side, the practitioner is able to analyze current status of decision space, capabilities, and accountability for 8 core functions that is listed on the left-hand side. In doing so, they're also able to document the implication and action areas to address the current situation. So across the dimension of decision space, practitioners are able to analyze where their organizations stand in terms of authority and responsibility in order to make decisions related to corresponding core function. Likewise, the practitioners are also able to simultaneously identify what kind of organizational as well as individual capacities are available and what kind of mechanisms are in place to shape the decision-making choices related to corresponding core function. When this analysis is completed for all domains and subdomains of the 8 core functions listed here, we yield a comprehensive view of the entire organization in terms of where the organization stands, both in their ability to fulfill the functions as well as what kind of gap exists and what they ought to do next. So in Uttar Pradesh, Johns Hopkins started this work after receiving the mandate for restructuring of the health directorate from the incumbent Minister of Health, as you can see from his tweet on the left-hand side back in the August of 2018. And in a span of nearly 1.5 years, we completed 6 steps that's listed on the right-hand side to conduct functional analysis and identify change option to address the issues facing the health directorate. The process started when with the establishment of high-level steering committee that included leaders of the health directorate itself. After that, we completed step number 2 of conducting interviews, field visits, and conducting policy and review that helped us to identify the issues facing the directorate. In the third step, probably the most critical step, what we did was we identified the principles for organizational changes and core functions that we wanted to fulfill through the reform process. We, as the research team that included health system experts, codified a list of principles considering the changes that various respondents verbalized during the key informant interviews. For us, the directorate was, the principle was that the directorate should be transformed into a modern public health executive agency with structures and systems that promotes collaboration and integrates dynamic approaches to deal with the emerging priorities. This is just a glimpse of analysis of one of the subdomain under the policy coordination and strategy core function. I won't go over the details included here, but just want to highlight that we were able to synthesize massive amount of data utilizing this framework, which ended up providing a very comprehensive outlook of the entire organization in terms of its capacity and where it stands in terms of its ability and authority to execute on constitutionally mandated executive functions. So really, as an outcome of applying this approach, we were able to identify what functions were missing, dispersed, poorly performed across the directorate, and if the health directorate really had capabilities and accountability mechanisms aligned to ensure those functions. In UP, what we found was that despite being the executive health agency of the state of Uttar Pradesh, which is like the 5th largest country in the entire world in terms of its population size, the directorate didn't really perform many of the core functions that are related to policy, regulation, financing, health promotion, and health protection. One of the most striking findings was that the headquarters of the directorate spent the majority of the time performing two support functions that are related to human resource management and legal services. So also another outcome as a product, a byproduct of this process, we were able to identify core functions and support functions that's not listed here that a modern public health agency ought to fulfill in order to address the emerging health priorities of the world. And lastly, perhaps the most important of all, we were able to utilize this approach both as a technical as well as a political tool that generated consensus among key stakeholders around key issues facing the health directorate, and then have consensus around the priority action areas. In this schema, you can see a summary of recommendation included in the reform packages, and this included a recommendation in order to address structural, behavioral, and capacity building issues facing the directorate. So to conclude, we think that functional analysis is a practical tool that has potential to facilitate building strong public health agencies in low and middle income countries that may not necessarily have individuals who are experts in complex health system frameworks that are out there. And we think that the framework that we presented is both an approach as well as a tool that provides practitioners with a ready-made list of core functions that are essential to fulfill as a modern public health organization with stewardship duties of the entire health system, and use those functions to systematically identify the issues related to it and build consensus around what needs to be done to strengthen them. Thank you.
Many thanks, Benita, for this presentation. We'll move now to our last presenter before taking question and answers and comments for our presenters. So I would like to introduce to you Dr. Juan Arroyo, who will talk about failed policies, from good design and management of policies to political systems and political regimes in health. Dr. Juan Arroyo is a researcher at the Pontifical Catholic University of Peru. He's a doctor in social sciences with a master in public health and sociology and specialization in public health and public management. He's been in Peru Chief of Cabinet of the Ministerial Office of Health and Vice Minister of Public Health. He's a professor and principal investigator at the University, Pontifical Catholic University in Peru, and the Universidad Peruana Cayetano Heredia. We are ready to watch his video recorded presentation.
Policies, from good design and management of policies to political systems and political regimes in health. There are continuous course changes, partial advances, overlaps, and simultaneous setback of the policies issues. What are the failed policies? Coming and goings or continuous changes of course. Re-releases of all policies as if they were new. Defer lawsuits that enter the agenda only when they explode. Policies offered but then abandoned or not implemented. A. Good design of policies and strategies obtained with more evidence. This technocratic bias corresponds to the old rationalist model explaining that a good part of the policies define their programmatic content. This turns public policy into prescriptive normative systems not appropriated for context of fragmented actors and low institutionalism. It is an approach of fast track that should be. They suppose with better input or evidence, it does not matter if the black boxes are defective. It assumes the relative autonomy of the formal formulators to have quality products without the low quality political system. B. Exemplary implementation by lending devices is obtained with more management and new incentives. But the reflection has been less on context of precarious democracies, ineffective states, and weak governments making a successful public policy. One response to ineffective public policies is to look not backward toward the system and political regime that produced them, but forward toward their implementation and delve into the problem of the provider state or regulatory and oversight state. Objective. Capture the regularities and reproduction scheme of this type of failed policy making and its policy fails. Methodology. Study 4 cases of policies in Peru in the period 2001 and 2019. 1. The local health administration committees manage health centers by receiving funds from the states, maintained inertially since 2004. 2. The Ministry of Health and Social Security articulation had 10 attempts at integration or articulation with resistance and setbacks. 3. The health promotion grand launch in 2002, then stopped and was abandoned by its director. 4. The Health Management Institute, created in 2009 and closed in 2010, left Peru's capital without a metropolitan health authority. Research techniques, in-depth interviews with ministers and sector managers of the period, reviewing existing regulations and documentation, and exhaustive analysis of national and international bibliography. Results 1. The founding of a typology problem in the public policy cycle, like that they periodically enter without solution, or when enter the agenda, they leave it badly. No attention has been paid to the prior moment of public policy system and sectoral political administrative frameworks. That determine the quality of policies being the black box that processes and implements decisions, analyzing the particular configuration of political regimes, their combination between politicians and bureaucrats, the weight of sectoral opinion, the role of the academic actors, the hegemonic and emerging discourses. The conceptual background of political science had not been adapted to the field of health. As a consequence, policies are studied as a policy but not as politics, not appropriate for contexts in which there is a chain between significant needs, few resources, fragmented actors, and low institutions. The traditional answer about whether it is a design or management problem is insufficient. The institutional architecture has affected the sustainability of public policies. Specific types of sectoral political regimes probabilistically promote a low or high quality of institutional response to relevant social problems. One thing is to study the analysis and another to study the formulation, decision, and operation pattern, revealing explanatory factors of the successes and limitations. Philosophies and paradigms are expressed, packaged as causal beliefs, circulating as dominant forces. The state is one of the principles of public order, and it is not just the policies and the army, as the Bavarian definitions suggest, monopoly of physical violence. Public order rests on consent. Conclusions. The political system has a polyarchy at the decision maker's apex. The predominant ideas come from non-expressed paradigms. 3. Policy evaluation focus on the reasons for non-implementation. 4. The input at Eastern black box, where policies are processed, come not from citizens, but also from the presidency and pressure groups. 5. When the health sector does not have an influential sectorial intelligentsia and public opinion, there is no impact. 6. Politics without policy makes the protocolization of the formulation process a random and underestimate. 7. Health policy evaluations are reduced to the binary success-failure formula. 8. Most of the literature on policy making is written from developed countries without considering the precarious states with fractures, political society producing low quality, sometimes simple rhetorical acts for the audience impossible to implement. 9. The evidence-based policy model adheres to the rational model of decision-making in the case of low institutional societies, encouraging excessive reliance on evidence and avoiding non-rational factors and institutionalism. 10th, the sectorial health regime is characterized by having a minister with presidential characteristics with the capacity to change state policies with not advisor but executives without sectorial government coalitions in the midst of passive dissent. 11. The question is how popular sovereignty is expressed sectorally or it is only through Congress. It is an autocratic sectoral political regime within a democratic or semi-democratic political system. Finally, there is a low viability for sectoral change because there is a fear of breaking public policy precarious balance. Discussion. 1. The study discusses its findings with the normative literature, ignoring reflection on the garbage can model mixed with incrementalism. 2. The study debates with approaches focused on design and results and focus on the political system or actors because the first one underestimate conversely the products or policies and we highlight the decision patterns. 3. The study debate with the idea of holistic public policy supported by general laws for contexts in which politics arises from a series of specific decisions.
Thank you very much, Dr. Arroyo, for this last presentation. Thank you for everyone for bearing with us for this live question and answer session. You have been putting your questions for our panelists in the Q&A box, and I'm going to select a few for sake of time. For our various panelists. There are a number of questions for Sarah Fisher actually. They're turning the idea of principal agent around makes total sense for our audience. But Sarah, do you think that we can, how can we extend such an idea and challenge power relations at local and national level? For example, do donor agencies routinely tackle ownership in their language of their call for proposals, guidelines for implementing and partner agencies? Can it be argued that if there is this language in the call for proposals, in the proposals, or in the design of interventions and activities, if NGOs have extensively and hopefully engaged with government and communities to identify priorities, can we claim community ownership in this instance? There are a set of questions that are quite similar related to that how of community ownership, of shifting that power relation of ownership. Could you please address that question first?
Yeah,
Sarah?
of course. Thanks, Dr. Mariam, and thanks to everyone for staying and watching and asking really interesting questions. I think this is these kinds of how questions are the really kind of obvious next step, right? Once you identify a problem, once you kind of set it within a framework that we think maybe is how things kind of look for the most part. The question is then like, how do we make that? How do we make those shifts? Because I think if we're here in this room today, I think we all agree that there should be community ownership, right? And that things should be kind of more bottom up, and there should be more accountability and things like that. So, and I don't think this is an easy question. Otherwise, we wouldn't all be here, right? So, I think there are multiple things and multiple levels at which we kind of need to start looking at these things. So, I mean, first, if we're gonna talk about the way that things are currently, we know that a lot of times, speaking of this sort of, the language in calls for proposal and things like that, oftentimes you'll get a sort of, a call for proposals from a donor organization within the home country, and this is kind of sent out, right? There are often very tight kind of timelines for turning things around. There's not a great opportunity to try to get that sort of engagement. So it's there needs to be a sort of rethinking when you're building proposals, to sort of start these processes in your prior project, right? I think, I don't think that this paradigm of kind of donors and NGOs is going away anytime soon, right? As much as I think that there are so many issues with it, I think they're here to stay. And so I think we need to reimagine within the framework that we have how to build on this, right? So ensuring that, like, while you're in the middle of projects, that you're constantly engaging those communities, right? In theory, they are the beneficiaries, right? And so there should be an open dialogue constantly, in terms of progress and what they prioritize and what's working and what's not working, so that when it comes time for those, snap turnaround, multi-million-dollar projects that come down, that you have some of that information already. And I think also from the donor side, they if they're, the language is very often in there, but it doesn't feel meaningful, right? If they don't allow for this kind of process, right? And I think there are projects that have done this well. I think that there are donors who do this well, but it needs to really be a kind of across the board shift in the way we think about kind of development projects and global health projects, and how we interface not just with national governments, but also with district governments and with communities. And then I think there's a lot to be said for civil society movements. I think that communities can organize, and they have a lot of power if only they would have that kind of that feeling like they can change things for themselves. And I think that's sort of a human problem, right? This is everywhere, where we just don't see enough action, and there's a lot of kind of lethargy in terms of trying to kind of tackle these power imbalances. But I think frontline health workers, community health workers can do a lot to sort of foster that feeling of agency. And this is not, I'm talking about an NGO project that uses community health workers. I think they can do it themselves as part of their job, right? And constantly having that dialogue as well. So I think it's a multifaceted issue, and I think it should come really from a lot of different angles. So just for the sake of time, I think there's a lot to be said there, but I'll stop there and allow questions for other people.
Thank you very much, Sarah. Actually, there are a number of questions for you, but they all revolve around that, how of the community ownership. I would like to maybe ask Armand to answer the same question, actually, from the perspective of health impact assessment, because we do often see health impact assessment as a very, let's say, heavy and dry assessment process. That a lot of projects would shy away from because of the nature of that assessment. But what you presented was you also referred to participatory processes and how then communities can shape these assessments. And that makes a link also between how communities shaping the assessment can also make their voice through policy making and policy implementation. Can you comment on that?
Well, definitely, the communities will have to play a big role in terms of how policies are implemented. I think the government should be careful on how these policies are being implemented, because it's really easy to write good policies, but policies written are not exactly policies as experienced. So it's very important for all of these policies of the national government to set up feedback mechanisms where communities can actually participate in, provide comments or grievances, for example. So that's really important. And I think even before implementation, communities should be able to contribute to how policies are developed, how they are conceptualized, how they are designed, because at the end of the day, they are the beneficiaries of these policies. And it's uh, parang I think it's about time that the governments should step out of their ivory tower and actually uh, think about what the communities are actually experiencing.
Thank you. Thank you very much, Armand. I will take another question and address it maybe to both Benita and Juan about because the question is really looking at how to catalyze participation or bottom-up approaches in more hierarchical top-down systems. And both of you have been looking at processes, functional, organizational processes, or policy processes at state level or national level, and the governance arrangements that underpin those processes. So how linking now this community ownership and the two presentations that we're looking at this more more specifically to your presentations, how to catalyze bottom-up participations in these reform processes, whether it's institutional reform or system reforms. How can that be fostered? Can we start with Benita, please?
Thank you, Mariam. Very interesting question. And just reflecting back on the work that we did in Uttar Pradesh, India, and linking that with what Sara was mentioning in terms of principal-agent relationship between the donors and the agent for us, we were brought in by the donor organization to support the state in health system strengthening. And as the academic partner, as the technical partner, we had a role, sort of more of the upper hand in terms of determining, giving them the suggestions on what to do, what not to do. But the approach that we really took was actually flipped that around and brought in the people and asked what are they facing, and asked them to identify what they ought to do in terms of improving the problems that they are facing. And that sort of participatory process within this Ministry of this Department of Health allowed the participants, who are the bureaucrats within this organization, to be the almost the principal of this process, and then change that relationship and bring in their ideas about how their organization should be reformed. And that sort of was an approach that was successful in this context. And similarly, to bring in the voice of the community, I think there needs to be this institutionalized process of bringing the voices of the community members and ensuring that voices are not actually diluted or lost along the process, and actually are translated in their own words and interpreted in the right manner for the policies. So I guess it's a process that allows, the process should allow the system to constantly reflect and also internalize that there are voices, that needs to be integrated. And it's all about building these inherent these processes within the system.
Thank you very much, Benita. I will move the question to Juan to tell us about how this, you were talking about the determinants, I would say, of failed policies, or how to analyze these processes that have not been able to yield results. What are your perspective about that community ownership within these processes, and how important that is?
Thanks for the question. I think all of us agree with the social participation of the communities and population in general, no? the matters, the thing is how do we do that in at national level, no? We can do that in local level. Is easier, no? But in national level, it is we have to imagine solutions, new solutions, and new ways to organize the ministers of health, no? The question is how popular sovereignty is expressed sectorally, because we have democratic regimes, but in the health sectors we are not democratic with the decision making. No? We have ministries that decide all, no? And we need to change the autocratic sectoral political regimes. No? That is the solution with new communities, committees, no? That they may have the opportunity to have an opinion, no? And decide in the political process, no? In the policy making of the new laws, no? That is the solution, I think, at that level, no? The national level, no? That's the things we can conclude of our research.
Thank you very much. I'd like to address a question to Andre. What I've heard from the other panelists is the role of the community health workers has come up as an important role in terms of bringing out as an instrument of community ownership, as a relay to community ownership. You've mentioned that role as well in your presentation. Can you elaborate maybe a little bit more on how the role they play in setting up good governance or governance instruments?
Yes, absolutely. Thank you for the question. So the role of community health workers is absolutely essential. I think that the whole body of health systems research during the past decade or so has demonstrated how crucial they have been. I know that there's been really interesting data from some of my South African colleagues in the Western Cape that have shown how how community health workers are essential in developing new policies and are essential in translating bottom-up policy directives into a national stage. It does remain to be seen, however, to what extent their roles are to be formalized. The problem is once they are being taken up by ministries of health and taken up into the formal structures of the government, they tend to lose some of their activist voice. This is a similar thing that I think has happened to a lot of NGOs across the world. So it's a very fine balance that needs to be done between keeping community health workers engaged in terms of their community role and becoming another arm of government just on their own. So that's definitely certainly a question that I think a lot of countries have to struggle with in the coming years.
Thank you very much. We have about 7 minutes left until the end of this panel session. I would like to take a question that's addressed to all panelists and summarize it and give you maybe 1 minute, 45 seconds each to try and give your views about that question because it's addressed to all of you. The question is actually a little bit complex, but I'm going to summarize it or simplify it. It says, how could we address governance and accountability under the top-down vertical policy implementation as it is happening now under COVID-19 pandemic context. Of course, there should be a question on the pandemic context, as we are now all online because of that. But I will say how could we expect power shifting to take place? That's a very complex question, and it's more than 45 seconds or 1 minute response. But more specifically, the second part of the question is about the role of the academia. And as I see, all of you are associated with the academia. So in the governance process, let's leave out the vaccine development and the clinical guidelines development, but in the governance process of COVID-19, what is the role of academia? What do you think your role as a researcher should be in that context? So I will start with Benita, and I will give you less than one minute for this response.
Thank you, Mariam. Pretty big question to answer, like you said, but just being a part of the academia and also very closely working with the practice community of policymakers. What I reflect is throughout this COVID-19 pandemic and, the kind of engagement that we continue to have with the policymakers, I think our role in this governance process is really to speak the truth, and that has been the theme of this the entire symposium as well. We need to reflect upon our own prejudices or our own and put that aside, and perhaps continue to point out where others remain, who are the marginalized, who are being left out, and shed a light on those areas through authentic research that we continue to do. And another thing that we have been continue to face is that policymakers continue to ask us questions about how do we solve this problem that we face every day when they go to work. And the beauty of academia is that we have engagement with a broader knowledge community.
We have 4 minutes left, so we have 4 presenters.
Okay, that's it. I'll allow others to speak. Thanks.
To wrap up? Thank you. So I heard speak the truth, look at vulnerabilities. Excellent points I'd like to highlight. Andre, would you like to share with us your thoughts about this?
Yeah, absolutely. I think I'll just shortly put this. As health system researchers and academics, I think we need to accept that the time for doing research and producing knowledge for policy without community participation is dead and buried, and it needs to be over. There's a very crucial deliberate step that needs to be taken in terms of how we do health systems research going forward, especially in the time of COVID-19, and community participation is front and central in that process.
Thank you. Keeping HSR alive in this time, it's extremely important indeed. Juan, would you like to share with us your thoughts briefly?
Yes, I think we have to change the focus of our attention. We have paid too much attention to the public policy without seeing the political system and sectoral political administrative frameworks that determine the quality of policies. We have to change the focus of our studies and to give solutions and evidence to policymakers. That is my...
Great. Thank you. Attention to political systems. Armand, would you like to share with us your thoughts?
Yes. Well, in the Philippines, we have a pretty much decentralized health system. So right from the start, I would say we've always been banked on the villages and the local governments for COVID action. So I would say what the national government can do is to really provide the resources and to capacitate these local governments. For the academy, we should be able to mobilize state universities, especially in the regions, in the provinces so they can help in supplementing capacity building efforts. Thanks, Mariam.
Thank you. Mobilizing local research capacity, extremely important. And I'll end up with Sarah.
Sure, thank you so much for the question. I think, I'd like, I agree with what everyone has said thus far. We need to look at vulnerabilities. We need to look at the local based, just on my presentation today, I think local ownership is more important than ever, right? In this sort of a situation. I fully agree with Dr. Arroyo that, this is political, this is highly political. We can see this everywhere in the world, right? And I think as academics, we have a lot of power to, as Benita said, speak the truth. And I think we need to kind of come together as like a unified health systems and research community and push policymakers in the sort of direction that we all know this needs to go, right? I think, piecemeal studies here and there are not going to be as powerful as a full kind of research community all pushing in the same direction.
Thank you very much for your set of answers. I'd like to conclude with a brief wrap up of what you just said, which I think is very important for this session. Speak the truth, shed the light on vulnerabilities, keep HSR alive, continue evidence for policy work, but also bring attention of policymakers to that this is a highly political debate that we are facing, context that we are facing. Political systems matter in policy making, and look at the local capacities, whether it's local governing capacities, local institutional capacities, and local research capacities. Thank you all very much for participating in this panel discussion and for sharing your work and your thoughts on the context of COVID-19 pandemic with us. Thank you to all our speakers, to all our audience to be with us and for the interesting questions that we had. And thank you to our host for making this possible.
Thank you all.
Thank you.
Thank you.
Thank you. Take care, stay safe.
You as well.